So the first specimen is a urine cytology specimen. The patient is a 55-year-old male. He presented with hematuria, which means blood in the urine for 2 weeks. So this is a new patient. The past medical history, he has been smoking for 10 years, but quit it for 20 years. So the image finding show that in the posterior wall of urinary bladder there is a mass lesion, and the patient had the urine cytology for cytology examination. So in this specimen, it's a little bit dry because of these artifact by the cytospin. So sometimes in this condition, when you see a lot of like atypical cells, you might probably need a repeat like cytospin to see if there are more preserved cells. So in this specimen, at the periphery of these small cycle, you see a lot of atypical cells with hyperchromasia. And okay, with hyperchromasia, but the chromatin pattern, it's not very easy to appreciate. The shape of the nucleus is very irregular. There were elongation, angulated, which is also abnormal. The NC ratio is slightly increased, but not very high. So basically, we have a typical urothelial cells, highly suspicious for urothelial carcinoma. And this is a new patient. So when there is a new patient, usually we will be more like we would need very definite finding because the patient might need a definite like a treatment. So here we see in a different cytospin circle, this is a much well preserved cells. You can easily appreciate the irregular coarse chromatin pattern such as these cells, right? And cell is highly degenerated because it's a voided urine specimen. So if it's a tumor cell, when it falling down into the urine, it can quickly get degenerated. Here we also see karyoresis cells. So based on the cytomorphologic like a feature, this is basically we have a lot of atypical cells, so it's highly cellular, and all of these cells show marked hyperchromasia. Some of the cells show like coarse chromatin, some with more apparent increased NC ratio, and the patient had a clinical detectable mass lesion at the posterior wall. So I think this is good that we can directly call this positive for high-grade urothelial carcinoma. So sometimes for the cytospin preparation, we use two-circle preparation for the urine now, because urine cytology, urine specimen is usually very how do you call that? It's very watery. So the cytospin is sometimes can easily get dry. And so not every circle that will show like a well-preserved cell, but in this one show well-preserved and one did not. But still, based on these well-preserved area, we can call this high-grade urothelial carcinoma. So urine cytology is highly specific for positive urothelial carcinoma finding, but it's not very sensitive because sometimes the cell is just very scant, and the other time the cell might be just degenerated. The next specimen is a very interesting one. We haven't seen this for a while. This is a 63-year-old male with pleura effusion. So on low power, basically the background is very clean. We don't have a lot of inflammatory cells, but the specimen is highly cellular, and we have a lot of these bowl-like three-dimensional architecture. So if we go to higher power, so you can appreciate that some of these clusters show the scalloping type of pattern. These could be adenocarcinoma. But if you pay attention to the morphology between these clusters at the adjacent, looks like mesothelial cell. These two looks very similar. Okay, so on the low power, you think, okay, the most common scenario is adenocarcinoma. But when you compare with the morphology, the chromatin pattern, actually you see very fine granular chromatin instead of vesicular chromatin. The nucleoli is not very apparent, and the overall nuclear feature is very similar to the adjacent mesothelial cell. However, this mesothelial cell also looks a little bit bizarre because the size is markedly increased. So the specimen is highly suspicious for a mesothelioma instead of adenocarcinoma. So mesothelioma can have apparent pseudo inclusion over here as well. Let's go to, here's another, a couple pseudo inclusion I haven't dotted, but it's not uncommon. So here another one. But the cell is quite large, right? It's basically a big cell compared to the adjacent inflammatory cells. So nowadays we have multiple markers for the diagnosis of mesothelioma. None of them are very sensitive, but all of them are very specific. So the first thing that we want to demonstrate is that the cell cluster, the cell ball, the cell origin of this cell, is it a mesothelian origin or is it like epithelial origin? So we use cell-specific marker. For the mesothelian origin, usually we would do creatinine, which can be positive for both benign, reactive, or malignant mesothelioma cells. The epithelial marker that we commonly use nowadays is Claudin-4. So we use these two markers to firstly show the three-dimensional cluster are actually from the mesothelian origin. And then we will move to the mesothelioma specific marker. What we have in our hospital now, we have three different markers. One is called BAP1. The other is called MTEP. So BAP1 is a gene, and the encoded protein will show loss of expression in about 50% of the mesothelioma. The MTAP is a surrogate marker for deletion of P16, which is CDKN2A. The one is the gene name, one is the protein name. So it is a surrogate marker for deletion of CDKN2A. And it's also like show 50% of the tumor will be lost. So this is also a marker. The third marker that we have now is called Merlin, which is an encoding protein for neurofibroma 2, the gene NF2. And it also shows deletion in a small subset of the cases. So if any of these three markers show loss of expression, we will be quite confidently to call this malignant mesothelioma. But if none of them show loss of expression, for these type of specimen, we would call this suspicious because of the cell ball morphology is highly unusual for exfoliated like pleura effusion is also highly unusual for any reactive type of mesothelial proliferation. If the specimen is not collecting during the surgery, if this is truly exfoliated like a specimen, so we will wait for the immunohistochemistry. But based on the cytomorphology alone, it is already suspicious for mesothelioma. So it is not very common to see this because it is a very rare tumor, and nowadays we don't have so many like a besto like because it's already forbidden to use for any construction. So this is the cell block preparation. Again, we see a lot of three-dimensional cluster of cells, but you can appreciate that all of them looks very similar to the single cell right adjacent to it. So this looks like a mesothelioma. Okay. So the next specimen is from a 81-year-old male. He had a history of squamous cell carcinoma of the gingiva, and this is a pleura effusion specimen. We had a couple SCC specimens today, but all of them are very difficult to make definite diagnosis. So this is a body fluid specimen. Like what I told you last week, that SCC is very uncommon to go to the body fluid, body cavity. In this specimen, we actually see some keratinized material. And some of the cell looks very atypical. It's highly atypical. However, the chromatin pattern, the pattern of the cytoplasm doesn't look like it is a SCC, right? Because we have vesicular chromatin, very prominent and very strange like shape nucleoli with abundant like bubbly cytoplasm. So these looks more like adeno instead of like phenotypical squamous cell carcinoma. So this is a very weird specimen, but in our experience, sometimes when the SCC in the terminal stage, the primitive undifferentiated SCC cell can actually look very similar to adenocarcinoma. So this is kind of strange. And then we see still these keratinized, well-differentiated cells in the body fluid specimen, which is very, very unusual. So in the cyto cell block preparation, in the background we actually see a lot of keratin material, like laminated material in the background that we didn't see in the cytology specimen. So overall, I think the specimen is highly suspicious for squamous cell carcinoma. However, because it's already very poorly differentiated, we still need to demonstrate the lineage-specific marker for SCC. So we use P40. If P40 is positive for these high-grade adenocarcinoma-looking cells, I think it is compatible with metastatic squamous cell carcinoma instead of adenocarcinoma. So we would do an immunohistochemical stain for demonstrate the differentiation of these very atypical malignant-looking cells. So the detailed sign is that in the background we still see some of these laminated keratin material. So this is also very strange for the body fluid specimen. So the next specimen is from a peritoneal washing in a patient with ovarian cancer and receiving debulking surgery. I think the specimen Yuzhe got the specimen. Yeah. So the specimen itself is not well preserved. The cell morphology is not well preserved. It's very dry. However, you can see there are a lot of pseudomonas calcification. So this is a specimen high with abundant pseudomonas calcification. So the most common scenario would be a serous carcinoma. However, if you go to the periphery of these pseudomonas calcification, the cytologic feature is actually a bit low grade comparing to the usual serous carcinoma that we see. So it would be a good idea to correlate with the histology. So is he a high grade serous or is he a low grade? So it looks like low grade, right? So basically, this looks very much like a low grade carcinoma. So Jia Yu had presented a case, right, at the annual meeting that was primarily diagnosed in the pleural effusion, and then we proved that it's originated from the ovary. So this is a very typical low-grade serous carcinoma. So for the low-grade serous carcinoma, usually the pseudomonas calcification will be more prominent than the high-grade serous carcinoma because, you know, when the body forms this laminated calcification material, it takes time. But for the high-grade serous carcinoma, the proliferation is very fast. So it is not that easy to form these many. But for the low grades, grow slower. And most of the pseudomonas calcification will forming in the fibrovascular core. So in this type of specimen, I think in the old time, the low-grade serous is called pseudomonas carcinoma or something like that. So which suggests that it has these like very abundant, you almost never see these abundant calcification in the serous specimen. Yeah, so these looks typical for low-grade serous carcinoma. And it is also not very common. So the next specimen is a pleural effusion specimen. So when you see an effusion specimen with a lot of proteinaceous material in the background, sometimes you have to pay special attention to this type of specimen. Now I find this type of specimen is getting more and more common. And malignant cell can sometimes like hiding in the background of the material. So it sometimes is not very easy to detect it. So the patient had an uncommon history. He had a history of renal cell carcinoma, but it is diagnosed as a collecting duct carcinoma, which is like a very poorly differentiated renal cell carcinoma. So in this specimen, we have some inflammation in the background. So some of the cell can be reactive mesothelial cell. However, this single cell looks very strange. It has abundant cytoplasm, but it is eccentric and it has cherry red nucleoli. So some of the cell looks very strange. And for example, this cluster, I'm not very sure because the arrangement looks like mesothelial cell. We have like intercellular windows over here, some with binucleation, which is typical for a reactive mesothelial cells. So this one seems to be in the same cluster. Could this be just highly reactive mesothelial cell? I'm not very sure. And here as well. So sometimes you can tell the reactive mesothelial cell looks more atypical than the mesothelioma that we just saw. Mesothelioma just usually looks very bland looking. The nuclear feature is very bland looking. So for this specimen, I find it's quite difficult because there were some cell I find it's definitely weird looking, but it is not in cluster, it is only the single cells. So for this type of specimen, this is the specimen that we would need the immunohistochemistry to demonstrate again the cell origin of these atypical cells. So is it PAX-A positive for renal cell carcinoma? So here again we have scant cells with very strange cluster but very scant. So in the background maybe a lot of these cells with nuclei are actually reactive mesothelial cell, but some may be renal cell carcinoma. So we still need the IHC to demonstrate that these are not mesothelial cell but a renal cell carcinoma, especially when they are not in cluster. Most of them were single cells. But these two cells looks very strange. It's like a triangle, like a very strange shape. So at least it is suspicious for metastasis, but we still need to demonstrate the origin of these uncommon scenario. So we will do the PAX-A and we will also do the mesothelial marker. So the next specimen, we have actually 3 different specimens from the same patient, from the same lesion. The patient had a past history of esophageal squamous cell carcinoma, and he was presented with a cystic lesion at the base of the oral cavity. It is a cyst, so the clinician do cystic aspiration, and he sent for the cytospin, also sent for direct smear. So in this specimen, we see a lot of very strange keratinized cells, but the nuclei are mostly degenerated, and you cannot see like clearly the nuclear feature. So we have an inflammatory background with a lot of debris, but also a lot of typical keratinized like cells. So in this scenario, it is highly suspicious for metastatic squamous cell carcinoma, but because of this specimen is now, you didn't have a good like a visual demonstration of SCC, we would call this suspicious, and we just make a note that it is highly suspicious for SCC, but we don't have enough material for definite diagnosis. So you have 3 consecutive specimens. 2 were the fluid specimen for cytospin. There is 1 direct aspiration and smear, which looks like these. Again, the background is highly inflammatory, and it shows a lot of debris. And we see scattered like keratinized cells, some with nuclear, some without. But the keratinization itself is very strange finding, because usually it won't present in a cystic lesion. Yeah, so this looks like a ghost cell. So we call these suspicious for metastatic squamous cell carcinoma. So the next specimen is a lung aspiration. The patient had a past history of endometrial adenocarcinoma. So the specimen is positive for adenocarcinoma, and is likely compatible with the history, like the metastatic lesion. So the next specimen is thyroid aspiration. It is from Guangdu Hospital, so we don't have the liquid-based cytology. So on low power, it's a very highly cellular specimen, and you already can appreciate there are some papillary architecture, and with fibrovascular core in between, so you can see some spindle cells. These are endothelial cells, like we call this transgressing vessel, like going through a cluster of epithelial cells. When we see papillary architecture, we still need to go to high power to check the cytomorphologic feature. For this case, the cytomorphologic feature, the nucleus are mostly rounded, and you didn't see ground glass appearance, you didn't see groove or pseudo inclusion, and there are a lot of microfollicular architecture like detaching from these larger cell fragments. So basically, these looks much more like a follicular tumor instead of a papillary thyroid carcinoma. So again, for a follicular tumor, there were still some differential diagnosis with this presentation. But first of all, we do see some colloid admixed with blood in the background, right? So Jiaru has presented a case which was a parathyroid gland tumor, and it can also look like this with very apparent papillary architecture and with like forming like hypercellular smear. But in that case, there is basically no apparent like a micro follicular pattern, and there is no colloid in the background. So with colloid, with micro follicular pattern, we know this is coming from a primary follicular derived lesion instead of non-thyroid lesion. So this is also very important. If we see these papillary architecture, the differential diagnosis within the follicular derived tumor include papillary carcinoma, of course. So you go to high power and you check the nuclear feature to make the distinction. And for the follicular tumor, sometimes you will get large fragment of papillary looking fragment, but you can still get a lot of detaching microfollicular cluster in the background, which is in this case. But do not forget the other non-thyroid lesion, because the most common scenario that you would call a parathyroid tumor with aspiration is called a follicular neoplasm of the thyroid. Okay, so this is a typical case for a follicular tumor. So we call this TBS4. This is the loose stem preparation. Again, we see a lot of colloid in the background and admixed with some blood, and we have some microfollicular cluster over here. So the last case is a pap smear. The patient had positive HPV testing, which is non-16, non-18 type, and she has been followed for pap smear for a couple years, and most of the time we call it ascus. So I think the case is still very typical for ascus. So you see basically very clean background, superficial intermediate cell in good ratio. The patient is, I think, 40 or 50-year-old female, and you see like enlarged nucleus of intermediate cells with moderate hyperchromasia, but you didn't see any halo around it. So basically one cell is not enough, so we had a couple to make diagnosis of ascus. Again, there is another, so the hyperchromasia is quite apparent, and the shape of nucleus is irregular, but there is no halo. So in this cluster, we have multinucleation and we have hyperchromasia, but there is still no halo. So I think it's okay that we call this is ascus pap smear. So this one is quite typical for ascus. Okay, so that's it for today.